This morning, and now we're going to go on to an even more interesting session, I think. Controversies in the management of recalcitrant chronic rhinosinusitis, and there are quite a number of controversies, and I think we have now 90 minutes, 4 excellent speakers, and so I think this is going to be a very interesting session. All the way from the United States of America, from Utah, we have Professor Richard Orlandi, and he is going to tell us about, you're going to tell us about controversies in the management of recalcitrant CRS. Please.
Thank you, Per. It's a pleasure and an honor to be with you today to discuss this topic. I'm just going to put this here. Thank you. I want to congratulate the conference organizers, first of all, for even having this conference. It's such a delight to see you all again and to be with you and to share our common interests, our common passions for sinusitis, and to just be in the warmth of each other's company. Obviously, I can only imagine many of us have set up a conference like this and we know how many details there are. I can only imagine for our conference organizers how many more details there were to worry about, to contemplate, and problems to work through. And I congratulate them and I thank them for all of the work that they've done, all their staff, to bring us here together and to bring us here safely. I would like to start off talking about these controversies. My goal today in this short presentation is to bring out some of the controversies, and then my colleagues who will speak after me, I look to resolve these controversies for us. So I'm going to ask the questions. I believe they are going to provide the answers. So what I'll be talking about today, what do we mean by recalcitrant? Let's define what we're talking about in this session. Were we not taught that chronic rhinosinusitis will resolve with ventilation and drainage? So there was this idea, I think, that many of us had early in our training when we were young registrars and residents and trainees, thinking, well, if I just do surgery, that will resolve the problem. Well, we've learned that that's not necessarily true. It's true sometimes, but it's not necessarily true. And so we'll talk about that as a little bit of a controversy. Why is that not true? Why do some cases become recalcitrant? If only we knew the answer to that question, then we could help our patients so much better. And how should we be managing recalcitrant CRS? Well, these are the things we'll be talking about, and I have no conflicts of interest in this discussion. So first of all, what do we mean when we talk about recalcitrant? I think our EPOS colleagues did a beautiful job just very simply defining this for us, and that is that recalcitrant is difficult to manage or to operate, not responsive to treatment. And a synonym, of course, is refractory, and this is straight out of the EPOS guidelines from last year. And I think that, as the EPOS group says, the steering group prefers the term recalcitrant or resistant or refractory. I think they all mean the same thing to us, but we'll use the term refractory. For my purposes in discussing this today, I'm going to mostly talk about surgically recalcitrant chronic rhinosinusitis. So in other words, we have a patient that is untreated, they receive treatment, they either get better or they don't, and we call that medically refractory or medically recalcitrant rhinosinusitis. But that's not terribly interesting, I think. It's interesting to some degree, but many of us are surgeons and wish to and think of things as medically recalcitrant is just a definition of a patient who can then go on to surgery. So let's talk about surgically recalcitrant chronic rhinosinusitis for the most part. So controversy number 1, this idea of surgically recalcitrant. Were we not taught that sinus inflammation resolved with ventilation and drainage? Many of these concepts come about through Professor Messerklinger and our dear departed friend, Professor Stomberger, who took a lot of Dr. Messerklinger's ideas and made them much more widely known. And in this book that he authored back in the early 1990s was kind of my Bible when I was going through my training. And in it, he said, Messer-Klinger also noted that after reestablishment of drainage and ventilation via the natural pathways, even massive mucosal pathology in the dependent frontal and maxillary sinuses usually healed. Mucosal changes, which up to then had been regarded as irreversible, returned to normal. So this idea of severe changes becoming normal again once the functional pathways of drainage were opened is something that really stuck with us and was very appealing and really defined this idea of functional endoscopic sinus surgery. However, there is some indication that this is not always the case. The Messer-Klinger technique does not provide a surgical cure for all inflammatory paranasal sinus disease. This was a hint toward what we would find as we continued on in our careers, that this was not always going to be the case. And in fact, Professor Staumberger says our worst results were obtained in those patients with diffuse polypoid rhinosinopathy. And so this is actually something that we all see. We, of course, see many other times where we are seeing surgical failures or recalcitrant patients with rhinosinusitis. And this is a picture of Professor Staumberger and Professor Messer-Klinger. And even in this book, which preceded Professor Staumberger's, the mucosa reacts by becoming to a greater or lesser extent swollen, a state of affairs which is at first reversible. Later, however, this reversibility may be lost. And so this idea of perhaps we should operate a little sooner rather than later, an idea that we're coming back to now through the work of Claire Hopkins and others, this idea that maybe intervening a little sooner is better than waiting until every medical therapy has been exhausted. This is not a new concept, going back even further, of course. This is Professor Hayek from about 95 years ago. It may be said that an accessory sinus, which has been intensively diseased, is more predisposed to reinfection than one that was previously normal. From the Fifth American edition of his book, published in German originally in 1898, so from even longer ago. So when we talk about the first controversy, I guess, in rhinosinusitis, well, what is the amount of surgery that we do for a patient who, before we consider them a failure in medical or surgical therapy? That when have we done all we could for that patient, and then we assign them to this label, this title of recalcitrant chronic rhinosinusitis? And that's hard to know. Per and I were discussing earlier this idea that we think of all patients, we have in the past thought of all patients as chronic rhinosinusitis, and we know better. We know that there are at least 7, 10, even more different endotypes and different classifications of patients medically. And then we also act like we talk about surgery like it's one type of surgery, whether a small opening of the maxillary sinus by removing the uncinate process, maybe a small part of the bulla, or a, quote, full house fess where all of the sinuses are opened, or even more extensive surgeries, drilling procedures in the frontal sinus, revision surgeries in the maxillary sinus that remove the entire medial wall of the maxillary sinus. So we act like all of these are the same type of surgery when we say a surgeon or a patient has failed surgery or is recalcitrant to surgery. But we need to understand that there are very, very much different differentiations and variances in those different things that we talk about. And we need to be sure when we talk about something that we are both talking about the same thing. When we say a patient has failed surgery, well, what surgery did they have? Is there scarring? Are all the sinuses open? Are they accessible to medical therapy, which we're finding to be more and more important than actually just ventilation and drainage? So things to think about as we talk about what is recalcitrant to therapy. Number 2, what causes chronic rhinosinusitis to remain recalcitrant after sinus surgery? So clearly, the most effective management strategies are the ones that address the underlying cause. And you're thinking, yes, Richard, that is incredibly obvious, but it is worth saying that surgery does not cure the underlying inflammation. And what is causing the underlying inflammation? If it's strictly obstruction, if it is strictly a diseased tooth that is infecting the maxillary sinus and causing severe inflammation, if we ventilate and drain that sinus, resolve the tooth issue, then that sinus will get better. But those are exquisitely rare cases that we're faced with. More often, it's all of the sinuses are inflamed. And when we think about even the concept of the osteomeatal complex, why would disease affect the posterior ethmoid and the sphenoid if it's simply an anatomic problem within the osteomeatal complex? So clearly there are underlying inflammatory changes that are caused by numerous sorts of things. And we talk about what's the cause of chronic rhinosinusitis being recalcitrant. Well, it's not just one cause. There are many causes. I think of it this way. Many, many different things can get you to the Arc de Triomphe in Paris, and there are many different avenues to get to chronic rhinosinusitis, and then of course recalcitrant chronic rhinosinusitis. And if we don't understand what those avenues are, if we don't understand what's going on in that patient, then of course we will not understand why they are failing their surgery. Now, what are those causes? There are many causes. These are the tables of contents from the EPOS 2020 document and the ICAR Rhinosinusitis 2021 document. But it just gives you a sense of how many different causes for recalcitrant sinusitis there are, and how many different causes for just chronic rhinosinusitis there are. And we'd like to think it'd be nice if this one was in this patient and this one was in that patient, but they probably interact. I'll be talking on Wednesday about aging. There's some evidence that age plays a role in chronic rhinosinusitis. Why is that? I won't give it away right now, but there are probably multiple factors at play. And so we have to think of these many avenues not just as one straight line to chronic rhinosinusitis, but they interweave with one another. Some of them that are probably the most commonly seen and that have evidence for surgically recalcitrant chronic rhinosinusitis in both documents that have evidence are biofilms, immunodeficiency, eosinophilia. We see this, the more eosinophils, the more likely we are, the more eosinophils in the tissue, the more likely we are to see persistence of disease. Neoosteogenesis is another one that we see with persistence of disease, whether that is a manifestation of severe disease or whether it actually causes problems after surgery or whether it's a result of surgery to some degree is, I think, up for discussion. And finally, just polyps. We know again, and related to eosinophilia, we know that polyps are the cause. So in each one of our patients, we need to be thinking to ourselves, why is that patient continuing to suffer? How may I serve him? So as a physician, we need to be asking ourselves, why? And it's an uncomfortable thing. We have to ask ourselves, what have we not done? What have I not done for that patient? What have I not thought about? We have to take on that patient's failure a little bit as our own to be able to serve that patient best. Is it anatomic? Did I miss some frontal sinus partitions? Did I cause mucus recirculation? Is it infectious? Is there an infection that I just have not fully eradicated? We used to put much more emphasis on infection than we do now. Is it primarily inflammatory? And is it infectious and inflammatory? In the United States, we talk about when you hear hoofbeats, you need to think about horses, think about common things. But there are zebras that we need to think about. What are some of the more rare things that could be going on? Is there a ciliary dysfunction? Is there some other issue going on that with this patient that I may not be thinking about? Could reflux be playing a role? All the different things that have somewhat that are not seen in every patient, but there's evidence to substantiate their involvement in at least some patients. What else can we be thinking about as a cause for that failure? And of course, that leads us into how should we be managing it? And I love this statement from the EPOS document because I think that it really gives us the best way to think about our failures and how to treat them. Guidelines have traditionally attempted to drive all patients through the same pathway. In reality, multiple interconnected pathways, multiple interconnected avenues are likely to be required to facilitate precision medicine. So we need to pursue not just one, but multiple avenues. Sometimes they are simple. It's an anatomic issue. We remove the frontal sinus partitions and we have an open frontal sinus that heals with very little inflammation. Or we have mucus recirculation. We remove that mucus recirculation bridge and the problem is resolved. These are my favorite ones. They are easy to fix. Not always that easy. Infectious, inflammatory, are they combining together? Do we need to do topical antibiotics? Not indicated in most patients, but certainly needed in some patients. Do we need to think about biologic therapy to really resolve that inflammation when topical treatments are not enough? Do we need to do more aggressive surgery, a so-called mega-antrostomy, where we widen the maxillary sinus down to the floor of the nose, or draft 3 or other types of frontal surgeries? So as we talk about these different things, that I wanted to, again, tee up this, putting the golf ball on the tee up this conversation for my colleagues. We've talked today about recalcitrant CRS. This concept has been present for hundreds of years. It continues to be present through our more modern functional endoscopic sinus surgery concepts. It has always been there. And I think that we have taken care of the easy sinuses by and large, but as tertiary rhinologists, as rhinology experts, we commonly see those that are not easily taken care of. Someone else has taken care of them, and we are seeing almost entirely recalcitrant patients in our practices. We need to be asking ourselves, what are the causes for these patients? Why are they seeing us? Why have they failed good therapy with our colleagues? And what can we do to effectively treat them? And certainly we need to individualize the understanding and the patient's treatment to make sure that we treat that patient effectively. I thank again all of you for being here, and I thank the conference organizers for this opportunity to address you.
Thank you, Richard. If you could just stay there, Richard, could you stay up there? Because I think that since we don't have a panel here, there's much to discuss. I'm sure there's some questions from the audience, a couple of short ones. I have one for certain. Yeah, how do we really know how to stage our surgery? When do we go all in, and when do we do the Stamberger, small operations?
That's a very good question, and one I don't have a very good answer to, but I'll try.
Okay.
To me, I think this is actually where medicine is thought of as an art and a science, and this is more on the art side, isn't it? I think that trying to decide how big a surgery to do, I was taught by David Kennedy, I think it was him that said it, big surgery for big disease, little surgery for little disease, or little openings for little disease, big surgery for big disease. So I find myself being more and more aggressive with surgery through my career, thinking that, this will resolve if I just do this little bit, and finding that it didn't, and then doing more, and then it did resolve. And so I'm a little more aggressive than I was 20, 25 years ago. I'm still not answering your question, you've noticed. But I think that for me, the surgery needs to be tailored to the patient's disease and understanding what is causing the patient's disease. If it's a polyp patient, really that is going to likely need all sinuses opened up. Even, I may even actually, if the polyps are all the way through to the posterior ethmoid and all the way through the anterior ethmoid, but there are not polyps and maybe there is minimal inflammation in the frontal or the sphenoid, I will still open those to be able to deliver topical therapy. I think that that's really what we're aiming for. In some patients, like I mentioned with an odontogenic infection, we simply need to ventilate the sinus, remove the infection, and that's enough. And so a simple maxillary antrostomy may be enough. I think it really depends on the disease, Per, and again, I'm not answering your question. How we stage them and how we define them is, I think, and how we talk to one another about them is, I think, something we need to do a better job with. And it's probably, again, a group such as this that can do that. And maybe that's the next EPOS 2025 or ARCARS 2026 that can do that, where we actually can begin to speak the same language in surgery.
Perfect. Thank you. Any more questions from the audience? Witzke?
So thank you very much, Richard. It was really a great talk. But I would like to have a small discussion about your last point, because we all feel this way. I do better surgery than the one before me and solve the problem. And most of the time, patients do better, so we sort of more and more get convinced of our truth. But if you look at all the data in the literature, there's absolutely none that proves that we're right. So I would suggest, if we are so convinced of our good surgery, that we actually do a study to show that.
Yes.
And that would really be a thing to do together, because you need massive numbers of patients to do a study like that. But to show that that is really true what we think.
I agree with you. I think it's a very good point. It would be threatening to our egos, certainly, right? And so we'd probably need a psychologist or psychiatrist on the team to help us through that.
Exactly.
But I think that to be able to really verify that that is true, and your point about it being a large number, because there's so much heterogeneity in that population that we would study, we would have to have very large numbers. But again, I think we would have to even define what we're talking about. I think both of you are absolutely correct. Yeah. It's a great point. Thank you.
Let's try.
Let's try. I like that.
Okay, thank you, Richard. We have to go on now, and you certainly put the ball on the tee, because now Professor Manuel